Here's a number I want you to sit with for a moment. In a prospective cohort that followed 335,060 women across Europe for nearly 2 decades, regular coffee drinkers showed a statistically significant reduction in postmenopausal breast cancer risk, an adjusted hazard ratio of 0.90. That's 335,000 women, nearly 20 years of follow up. And that signal, modest but real and consistent, kept appearing across study after study, cohort after cohort, on multiple continents in women whose hormonal environment had already shifted. Most women who drink coffee every morning have no idea that number exists. And the women who have heard something vague about coffee and cancer almost certainly don't know that the protective association is specifically more pronounced after menopause than before. That distinction is not a footnote, it's the entire story. I'm Dr. Jessica Ward, Integrative Oncology researcher. For 15 years, the center of my work has been reviewing the literature on how cellular health, cancer biology, and metabolic function operate differently in women after the hormonal environment shifts at menopause. The gap between what the general health conversation tells women in their 60s and what the women-specific research actually demonstrates, that gap is significant, and it's the reason this channel exists. Before we go any further, I need to be direct about something. Everything I'm sharing today is educational information grounded in peer-reviewed research. It is not a substitute for medical care. If you have a personal history of cancer, any cancer, or if you are currently under treatment, including tamoxifen, aromatase inhibitors, chemotherapy, or any oncological protocol, please work closely with your healthcare provider before implementing anything you hear here. That's not a formality I'm rushing through. Women watching this video are often managing real medical complexity, and this information is meant to complement that care, never to replace it. Now, what almost no health content addresses, and what makes this conversation genuinely different, is this: the biological mechanisms through which coffee affects cancer risk and cellular aging are not equally active across all women at all life stages. They are specifically, measurably, more relevant after menopause. The research doesn't just show a correlation between coffee and reduced cancer risk. It shows that the correlation is stronger in postmenopausal women than in premenopausal women, and the molecular reasons for that difference are now well enough documented that we can actually explain why. Hundreds of videos exist about coffee and health. None of them ask this specific question: why does coffee's protective effect on cancer risk become more pronounced after the hormonal threshold of menopause? That's the question the research allows us to answer today, and the answer has real implications for a ritual that millions of women already have every single morning, and for what you add to it. If evidence-based research specifically designed for postmenopausal biology matters to you, subscribing to this channel takes 1 second. No generic senior health advice here, just the science built for women whose biology has crossed the hormonal threshold that changes everything. Let me start with the evidence, because that's where any honest conversation on this topic has to begin. The clearest picture of coffee and breast cancer risk in postmenopausal women comes from a 2021 meta-analysis published in the Annals of Palliative Medicine, led by Lee and Ma. This wasn't a small study. It synthesized 26 separate studies, a combination of case control and prospective cohort designs covering 26,168 breast cancer cases. The overall finding across all women was a relative risk of 0.95, a statistically significant, if modest, inverse relationship between coffee intake and breast cancer risk. But the critical data sits inside the stratified analysis. When the researchers separated women by menopausal status, the effect was measurably more pronounced in postmenopausal women, with a relative risk of 0.94 compared to a weaker and less statistically consistent effect in premenopausal women. The dose-response analysis across the cohort studies showed that each additional cup of coffee per day corresponded to a relative risk of 0.98. That arithmetic compounds with regular, sustained consumption. The European data strengthens this considerably. A 2018 meta-analysis in the journal Nutrients, led by Lafranconi and colleagues, synthesized 21 eligible cohort studies covering more than 1 million participants and 597 breast cancer cases. The centerpiece of that analysis was the European Prospective Investigation into Cancer and Nutrition, EPIC, which followed 335,060 women from 1992 through 2010. The adjusted hazard ratio for the EPIC cohort was 0.90, meaning that in post-menopausal women who were regular coffee drinkers, breast cancer risk was approximately 10% lower than in non-drinkers, even after controlling for diet, exercise, body mass index, smoking, and other confounders. The dose-response relationship in the overall meta-analysis showed progressively lower risk with increasing coffee consumption, specifically in postmenopausal women. The next finding inside that same Lafranconi analysis was the one that most directly pointed toward mechanism. The Spanish Sun Project, which tracked 10,812 women over 115,802 person years, found that women drinking more than 1 cup of caffeinated coffee daily had a hazard ratio of 0.44 for breast cancer compared to non-drinkers, a 56% relative risk reduction. And this effect was entirely absent in women who drank decaffeinated coffee, zero effect in the decaf group. That one comparison tells us something mechanistically important that most of the broad coffee research misses. Caffeine itself, not just coffee's polyphenol content, is a meaningful contributor to the protective signal in postmenopausal women. We'll come back to why that's true at the cellular level in a moment. The third major data set is the Women's Health Initiative Observational Study, published in the European Journal of Nutrition in 2022 by Yagjan and colleagues. This cohort included 77,688 postmenopausal women, all without a prior cancer history at enrollment, and prospectively tracked their coffee and caffeine intake against breast cancer incidence across different receptor subtypes, and specifically examined interactions with hormone replacement therapy. I want to be transparent about these results. They are more nuanced than the European meta-analyses. The relationship between coffee and cancer risk in the WHI data varied by estrogen receptor status and by whether women were using hormone therapy. This complexity matters. It means the story isn't simply coffee is universally protective for all postmenopausal women, regardless of their medical context. The relationship is real and biologically meaningful, but individual circumstances, particularly concurrent hormone use, affect how it plays out. That's exactly why the conversation with a physician who knows your history is irreplaceable. And then there's the hepatocellular cancer data from a 2025 review published in Science by Kuznetsov, Lahochky, and Laukkanen, a comprehensive synthesis of coffee consumption across multiple cancer types and longevity pathways. For liver cancer specifically, women drinking more than 3 cups of coffee daily showed a hazard ratio of 0.73 compared to non-drinkers, a 27% reduction in risk that held statistical significance. What makes this important beyond the liver cancer finding specifically is that the mechanisms driving that reduction, AMPK activation, mTOR suppression, modulation of insulin signaling, autophagy upregulation, are exactly the same mechanisms that operate in breast cancer, colorectal cancer, and endometrial cancer risk. The hepatocellular data is, in a sense, a window into the molecular story, and that molecular story is where the postmenopausal dimension becomes essential to understand. Because here's the question the epidemiological data raises, but cannot answer by itself. Why does coffee's protective effect show up more consistently after menopause? What biological shift at menopause makes coffee's compounds specifically more relevant? The answer involves 5 interconnected mechanisms, all of which are directly altered by what happens to a woman's hormonal environment after her estrogen disappears. The first mechanism begins with a compound most people have never heard of, despite consuming it every morning. Chlorogenic acid, abbreviated CGA, is the most abundant polyphenol in coffee. A regular coffee drinker absorbs between half a gram and a full gram of chlorogenic acid daily. What chlorogenic acid does inside the liver is remarkable. It inhibits an enzyme called glucose 6 phosphatase, which is one of the primary enzymes responsible for hepatic glucose production. When this enzyme is inhibited, the liver releases less glucose into the bloodstream after meals. Less postprandial glucose means a smaller insulin response, and a lower, steadier insulin environment means lower levels of insulin-like growth factor 1, or IGF-1, a signaling molecule that, when chronically elevated, functions as a systemic promoter of cellular proliferation, including, under the right conditions, cancer cell proliferation. Insulin and IGF-1 essentially tell cells to grow. When those signals are chronically elevated, cells that were already on the edge of abnormal behavior can tip over that edge. Now, here's where the post-menopausal layer becomes not just relevant, but central. Before menopause, estradiol, the primary and most biologically active form of estrogen, was a significant regulator of hepatic insulin sensitivity. It acted through estrogen receptor alpha in liver tissue to help maintain glucose homeostasis and limit the kind of gluconeogenic activity that drives insulin resistance. When estradiol disappears at menopause, that protection disappears with it. The liver becomes substantially more prone to what researchers call estrogen deficiency-related metabolic reprogramming, impaired glucose uptake, increased fat deposition in the visceral compartment, progressive insulin resistance. In the Women's Health Initiative data, post-menopausal women without hormone therapy showed substantially higher fasting insulin and higher HOMA-IR, a standard measure of insulin resistance, than age-matched premenopausal controls. And elevated insulin and IGF-1 are independent risk factors for ER-positive breast cancer, endometrial cancer, and colorectal cancer, the cancers whose incidence rises most sharply in the post-menopausal decade. The analogy I find most accurate. For decades, estradiol was quietly managing your liver's metabolic response to every meal you ate. It was a full-time general manager. When it retired at menopause, it left without a replacement. Chlorogenic acid from your coffee steps into one specific function of that role, moderating the liver's glucose output through a completely different molecular pathway. It doesn't replace estradiol, nothing does, but it engages the same metabolic problem through a mechanism that doesn't require estrogen receptors. Researchers have pointed out that the pathway through which chlorogenic acid moderates glucose metabolism, AMPK activation with downstream suppression of hepatic gluconeogenesis, is strikingly similar to the primary mechanism of metformin, the most widely prescribed diabetes medication in the world. You're not getting pharmaceutical doses from your coffee, but you're activating the same lever gently with every cup. That brings us to the second mechanism, which is where caffeine specifically enters the cellular picture and where stem cells become part of the conversation. Caffeine is widely understood as a stimulant. What is less widely understood is that caffeine also engages a pathway called AMPK, AMP-activated protein kinase, through its effects on cellular energy balance. AMPK is often called the master energy sensor of the cell, and that framing is precise. When AMPK is active, the cell simultaneously initiates autophagy, which is the cellular cleaning process that breaks down and recycles damaged proteins and dysfunctional organelles, suppresses mTOR, a signaling hub that drives cell growth and division and that is overactivated in the vast majority of human cancers, and promotes the creation of new mitochondria. These three actions together, clean house, slow, aberrant growth signals, build better energy infrastructure, represent exactly the kind of cellular maintenance that becomes more important and simultaneously more difficult to sustain as we age. The connection to stem cells is direct. AMPK activity is essential for maintaining the function of both hematopoietic stem cells, the blood and immune stem cells in bone marrow, and mesenchymal stem cells, the cells responsible for bone maintenance, connective tissue repair, and fat regulation. As AMPK activity declines with age, these stem cells age faster, lose self-renewal capacity, and shift their differentiation patterns in ways that are broadly unfavorable. The postmenopausal piece of this mechanism is documented and specific. Before menopause, estradiol was a direct modulator of AMPK activity in liver, muscle, and bone marrow tissue through both genomic and non-genomic estrogen receptor signaling. When estradiol disappears, AMPK baseline activity in these tissues decreases measurably. The consequence in bone marrow is particularly well documented. Mesenchymal stem cells in postmenopausal women preferentially differentiate into adipocytes, fat cells, rather than osteoblasts, the bone-building cells. This is one of the core molecular reasons why bone density falls and visceral fat accumulates simultaneously after menopause. It's not just caloric change. It's a shift in stem cell instruction. A 2021 paper in Frontiers in Pharmacology examined what chlorogenic acid from coffee does when it encounters human mesenchymal stem cells under conditions of oxidative stress, the kind of chronic low-level oxidative damage that accumulates in aging postmenopausal tissues. Under these conditions, human mesenchymal stem cells lose mitochondrial integrity, accumulate nuclear damage, and shift their differentiation toward fat. What the researchers found: chlorogenic acid treatment protected these cells from oxidative damage, restored mitochondrial membrane potential, measured by JC1 staining, a direct measure of mitochondrial efficiency, reduced the markers of oxidative damage, increased tumor suppressor gene expression, and, critically, preserved the cell's capacity for osteogenic differentiation rather than adipogenic. These were human mesenchymal stem cells. In a dish, not in a woman's body. That caveat matters, and I'll hold it. But the mechanism is grounded in human cell biology that we understand. Think of your mesenchymal stem cells as a highly skilled construction crew that, before menopause, received clear blueprints from a general contractor called estradiol. Build bone here, repair connective tissue there. The crew knew their job. After menopause, the contractor retired. The crew is still there, still capable, but they're receiving increasingly confused instructions from a noisier, more oxidatively stressed environment. They start defaulting to the easiest task available: building fat. The AMPK activation provided by caffeine and chlorogenic acid is mechanistically like correcting the blueprints, not restoring the original contractor, but giving the crew cleaner, clearer signals about what to build. The third mechanism is where the most direct anti-cancer evidence sits, and where the post-menopausal dimension connects to specific cancer types that become dramatically more common after estrogen loss. The pathway is called WNT beta-catenin. If AMPK is the cellular energy regulator, WNT is the growth accelerator. WNT signaling controls cellular proliferation, survival, and, when it's dysregulated, metastatic behavior. It is overactivated in a substantial proportion of colorectal cancers, endometrial cancers, and breast cancers. Oncologists sometimes describe constitutively active WNT signaling as a gas pedal that's been taped to the floor. The cell doesn't stop getting signals to grow. A 2022 study published in Nutrients examined what chlorogenic acid and coffee extracts do to WNT beta-catenin activity in human colorectal cancer cell lines. In the SW480 line, which carries a constitutively active WNT mutation, modeling a more aggressive tumor genotype, both chlorogenic acid and coffee extracts significantly reduce the transcriptional activity of beta-catenin, the key effector molecule of this pathway, and reduce the activity of the downstream transcription factor, TCF. The concentrations that produce these effects were equivalent to what you would absorb from 1 to 2 cups of coffee. That's in vitro data, important, but not the same as a clinical trial in women. What is specifically compelling for postmenopausal women is the hormonal context. Before menopause, estradiol exerted a direct inhibitory effect on WNT signaling in estrogen-sensitive tissues, in breast epithelium, colorectal epithelium, and endometrium. Estradiol suppressed WNT's baseline activity in precisely the tissues most vulnerable to WNT-driven cancer. When estradiol disappears at menopause, that inhibitory signal disappears with it. WNT signaling in these tissues becomes more active, and the timing maps almost exactly onto the incidence curve. Colorectal cancer, endometrial cancer, and ER-positive breast cancer all show their steepest rises in the decade following menopause. The removal of estrogen's WNT suppression is a plausible and mechanistically coherent contributor to that pattern. Chlorogenic acid engages this pathway through a mechanism that does not require estrogen receptors. It works regardless of whether estrogen is present or absent, which means it continues to apply WNTT inhibition in postmenopausal tissues where the estrogen-mediated suppression is gone. That's not a small thing. The gas pedal that was taped down when estrogen left, chlorogenic acid helps loosen the tape, not remove it entirely, but apply measurable resistance to a pathway that, after menopause, is running with fewer natural brakes. The fourth mechanism involves visceral fat, and this is the mechanism that most directly explains why the metabolic benefits of coffee are specifically more impactful after menopause than before. Postmenopausal visceral fat is not inert tissue. It's a biologically active organ that does three things simultaneously that all increase cancer risk. It converts androgenic hormones into estrone, the weakest and most oncologically problematic form of estrogen, through an enzyme called aromatase. It secretes pro-inflammatory cytokines including IL-6, TNF-alpha, and leptin that create the chronic low-grade inflammatory environment that cancer exploits. And it generates insulin resistance, which feeds back into the elevated IGF-1 signaling we covered in the first mechanism. These three activities create a self-reinforcing cycle. More visceral fat means more estrone, more inflammation, more insulin resistance, which together create a more permissive environment for cancer cell survival and proliferation. Before menopause, estradiol distributed body fat in the gynoid pattern, concentrated in hips and thighs, where it has lower metabolic activity. After estradiol disappears, the body redistributes fat to the visceral compartment in an android pattern. This redistribution is not primarily about calories. It's a direct consequence of the hormonal regulation of adipogenesis. In postmenopausal women with higher visceral fat, circulating estrone levels can be 2 to 3 times higher than in lean postmenopausal women. That estrone, weaker than the estradiol you use to produce but still capable of activating estrogen receptors in breast and endometrial tissue, represents a persistent, low-intensity hormonal stimulation of exactly the tissues where ER-positive cancers develop. It's not the same as the estradiol your ovaries were producing, but it's enough to matter. Caffeine increases thermogenesis and lipolysis, the breakdown of stored fat for energy, in a way that preferentially targets visceral adipose tissue, particularly when combined with physical activity. Chlorogenic acid improves hepatic glucose metabolism, reducing the conversion of excess circulating glucose to new fat tissue. Together, these effects progressively reduce the visceral fat depot that, in postmenopausal women, functions as both an estrone factory and an inflammation generator. The Geroscience 2025 review by Knutsor and colleagues documented coffee's involvement in this metabolic axis specifically, noting its role in the management of the postmenopausal metabolic syndrome pattern, visceral adiposity, insulin resistance, dyslipidemia, elevated inflammation. Coffee doesn't reverse postmenopausal metabolic changes, but it applies evidence-based counterpressure to multiple nodes of that cycle simultaneously. The fifth mechanism involves a category of compounds in coffee that most people have never heard of, and that are present in different amounts depending on how you prepare your cup. Diterpenes, specifically cafestol and kawil, are lipid compounds present in significant quantities in unfiltered coffee, espresso, French press, Turkish coffee, and mocha pot preparations. They are largely retained by paper filters in drip coffee. In vitro research has shown that cafestol and kawil activate a master antioxidant transcription factor called NRF2, which coordinates the cell's defense against oxidative stress and DNA damage. NRF2 activation upregulates a broad program of antioxidant enzymes and has been associated with reduced cancer risk in multiple cell types. Cafestol and Kawil have also shown direct pro-apoptotic activity in cancer cell lines, meaning they appear to trigger cell death preferentially in abnormal cells over healthy ones. This has been demonstrated in colorectal, prostate, and mammary cancer cell lines. Again, in vitro data with the limitations that implies. The postmenopausal relevance of NRF2 is documented. NRF2 activity declines with age, and this decline is exacerbated by estrogen loss, since estradiol was a direct activator of NRF2 signaling in multiple tissue types. Postmenopausal women have measurably reduced NRF2-mediated antioxidant defense compared to premenopausal women of similar health status. Cafestol and Kawil offer an alternative activation route that doesn't require estrogen receptors. There's an important safety consideration with diterpenes that I want to be direct about. Cafestol and Kawil raise LDL cholesterol, bad cholesterol, in a dose-dependent manner. This is well documented and clinically significant. In women with elevated LDL or established cardiovascular risk, which is a meaningful subset of postmenopausal women, given that estrogen's cardioprotective effects also disappear at menopause, high consumption of unfiltered coffee poses a real cardiovascular risk that outweighs the potential anti-cancer benefit. For women with any history of elevated LDL, cardiovascular disease, or statin use, filtered coffee is the more appropriate choice. The filter removes the majority of cafestol and Kawil while preserving nearly all of the chlorogenic acid, so you retain the most evidence-backed compound while mitigating the cardiovascular risk. For women without cardiovascular concerns, 1 to 2 espressos daily likely represents a reasonable balance. Now, I've reviewed the research and I've walked through the 5 mechanisms, each with its postmenopausal layer. The question that follows from all of this is practical. What does the evidence actually support doing, specifically for women over 60 whose biology has crossed the hormonal threshold that changes all of these pathways? Before I answer that, let me be precise about something important. Everything I'm about to share is meant as a complement to your existing care, not a replacement for it. If you're under medical supervision for any cancer, hormonal condition, or cardiovascular issue, bring this information to your physician and work through it together. They know your specific history. I'm synthesizing population-level research. Both perspectives are necessary. The first priority, and the one with the strongest evidence base for postmenopausal women specifically, is optimizing the coffee you're already drinking. And the single most impactful change you can make today, at essentially zero cost, is replacing any sugar in your coffee with Ceylon cinnamon. Not cassia cinnamon, the common grocery store variety, but Ceylon cinnamon, also called true cinnamon, available in most natural food stores and online. The distinction matters. Cassia cinnamon contains coumarin at concentrations that can cause hepatotoxicity with chronic daily use. Ceylon cinnamon contains less than 0.04% coumarin, making it safe for regular consumption. The evidence base for Ceylon cinnamon in postmenopausal women is solid. Its active compounds, cinnamaldehyde and cinnamic acid, improve insulin sensitivity and reduce fasting glucose through mechanisms that are synergistic with chlorogenic acid. Multiple studies in women with metabolic syndrome have shown measurable reductions in fasting glucose and improvements in HOMA-IR with daily cinnamon supplementation. Postmenopausal relevance. Both these compounds engage insulin resistance, the primary metabolic consequence of estrogen loss, through pathways that chlorogenic acid targets from a slightly different angle. Together, they apply broader pressure on the exact problem that elevated IGF-1 creates after menopause. The practical dose is 1/4 to 1/2 teaspoon per cup of coffee, stirred in before you add anything else. That's the full intervention. No pill, no supplement, no cost beyond a bag of spice. One safety note on cinnamon. If you're taking anticoagulants, warfarin, or one of the newer oral anticoagulants like apixaban or rivaroxaban, Ceylon cinnamon has mild antithrombotic activity. It's not a significant interaction at modest dietary doses, but it's one to mention to the physician managing your anticoagulation, particularly if your INR is tightly managed. The second priority is controlling the quantity and timing of the coffee itself. The epidemiological evidence converges around 2 to 3 cups of filtered coffee daily as the range where protective associations are most consistently observed in postmenopausal women. Below that threshold, the dose response data shows weaker effects. Above 4 cups daily in postmenopausal women, the risk profile shifts because of calcium excretion. Coffee at high doses increases urinary calcium loss, and in a population where bone density is already declining due to estrogen loss, this is a real concern. 2 to 3 cups before noon is the evidence supported range. Timing also matters, and this is specifically relevant for women taking levothyroxine for hypothyroidism, a common medication in this age group. Coffee significantly impairs the absorption of levothyroxine when they're taken together. The protocol is straightforward. Take levothyroxine with plain water on an empty stomach, then wait 30 to 60 minutes before your coffee. Women who reverse this order, coffee first, then levothyroxine, can develop substantially lower circulating thyroid hormone levels, even at an otherwise adequate dose. It's a fixable problem, but it needs to be fixed. The third priority applies specifically to women who are currently taking bisphosphonates for bone density, medications like alendronate, risdronate, or ibandronate. These medications need to be taken with plain water, and the patient must remain upright and avoid eating, drinking, or taking any other medications for at least 30 minutes after the dose. Coffee, because of its calcium binding properties and effect on gastric motility, should be avoided during this window. The bisphosphonate protocol and the morning coffee are compatible. They just cannot overlap. For women on tamoxifen, the evidence on coffee and tamoxifen interaction is genuinely uncertain, which is important to say clearly. Caffeine modestly inhibits CYP1A2, an enzyme involved in tamoxifen metabolism. Theoretically, this could affect the conversion of tamoxifen to its active metabolites. The clinical significance of this interaction at the level of 1 to 2 cups of coffee daily is not established. The effect appears to be minor, but it's the kind of uncertainty that belongs in a conversation with your oncologist, not resolved by a YouTube video. 1 to 2 cups in the morning is likely to be fine for most women on tamoxifen, but likely to be fine and confirmed safe for your specific situation are meaningfully different statements. Please have that conversation. For women managing cardiovascular risk or taking statins, filtered coffee at 2 to 3 cups daily is considered safe with statin therapy. The concern with coffee and cardiovascular risk is specifically with unfiltered coffee and the diterpenes we discussed, cafestol and caweol. If your LDL is elevated or you have a history of cardiovascular disease, use filtered coffee or espresso, which has lower diterpene content than French press or Turkish coffee, despite being unfiltered because of its small volume. For women with acid reflux, which is more common after menopause because estrogen was contributing to lower esophageal sphincter tone, coffee on a fully empty stomach can exacerbate symptoms. Taking coffee with even a small amount of food reduces gastric acid stimulation without meaningfully diminishing the bioavailability of chlorogenic acid. For women with known cardiac arrhythmias or atrial fibrillation, caffeine can trigger arrhythmic episodes in susceptible individuals. This is one of the populations where the risk-benefit calculation on caffeinated coffee shifts. Decaffeinated coffee still delivers chlorogenic acid and is not associated with arrhythmia risk. If you have a documented arrhythmia, discuss caffeinated coffee intake with your cardiologist. The fourth intervention in the evidence-based protocol is combining your morning coffee with physical movement, and the specific combination the research supports for postmenopausal women is coffee approximately 45 minutes before resistance training or brisk walking. The mechanism behind this timing is twofold. Caffeine taken before exercise increases adrenaline release and AMPK activation simultaneously, which mobilizes stored fat, preferentially from visceral adipose tissue, for oxidation during the exercise bout. The chlorogenic acid from the coffee further attenuates the post-exercise glucose and insulin response. In the context of postmenopausal women specifically, where visceral fat is both more abundant and more metabolically active than in premenopausal women, this combination creates a compounding effect. Coffee reduces the efficiency of fat storage, exercise increases fat oxidation, and together they progressively shrink the visceral depot that generates estrone and pro-inflammatory cytokines. For women who can tolerate it, the optional addition of MCT oil, specifically C8 caprylic acid, at 1 to 2 teaspoons in the morning coffee adds a third mechanism to this protocol. MCT oil elevates beta hydroxybutyrate, a ketone body, even in the absence of a ketogenic diet. Beta hydroxybutyrate activates AMPK in brain and peripheral tissues and promotes autophagy, cellular self-cleaning, in a way that synergizes with caffeine's AMPK effects. The combination of caffeine plus MCT oil taken in the morning before exercise creates what the research describes as a window of maximal AMPK activation and autophagy, which is the cellular state most associated with protection of stem cell function and suppression of mTOR-driven proliferation. Start with half a teaspoon and increase gradually. MCT oil causes significant gastrointestinal discomfort in some people if introduced too quickly. It's contraindicated in women with gallbladder disease, liver disease, or pancreatitis. Turmeric with black pepper is the fifth component of the evidence-informed protocol, and it engages a third molecular target, NF-κB, the master inflammation transcription factor, that coffee's compounds address less directly. Curcumin, the active compound in turmeric, inhibits NF-κB, STAT3, and the WNT pathway through mechanisms that partially overlap with and partially complement what chlorogenic acid does. The bioavailability of curcumin on its own is extremely low. It's rapidly metabolized and excreted before it reaches therapeutic concentrations in tissue. Piperine from black pepper increases curcumin absorption by approximately 20-fold. 1/4 teaspoon of turmeric with a small pinch of freshly ground black pepper stirred into your coffee is the dose supported by pharmacokinetic research. The coffee's fat content from any MCT oil or non-dairy milk you're adding further improves curcumin absorption, since it's fat-soluble. Taste-wise, turmeric in coffee is an acquired preference. It adds a mild earthiness that many women find acceptable, especially when combined with cinnamon. What not to add to your optimized morning coffee is as important as what to add. White sugar directly antagonizes the primary mechanism of chlorogenic acid by spiking the glucose and insulin response that CGA was working to moderate. If you need sweetness, a small amount of stevia or monk fruit sweetener doesn't affect insulin signaling. Large amounts of conventional cow's milk bind chlorogenic acid and reduce its bioavailability. The milk proteins and calcium appear to form complexes with CGA that resist intestinal absorption. Unsweetened plant-based milks like oat milk without added sugar or almond milk have less of this binding effect. Conventional flavored coffee creamers contain a combination of glucose, modified starch, and hydrogenated oils, all of which are directly antagonistic to AMPK activation and insulin sensitivity. They essentially undo multiple mechanisms simultaneously. What does the timeline of effects actually look like based on the research? The honest answer involves separating short-term from long-term effects because the evidence operates on different timescales. In the first 1 to 2 weeks after implementing these changes, switching sugar for Ceylon cinnamon, adding turmeric with pepper, managing timing around medications, women who were experiencing significant glucose lability after meals may notice some improvement in post-meal energy stability. This is the chlorogenic acid and cinnamaldehyde moderating postprandial glucose response. It's real and relatively fast, but it requires that there was meaningful glucose variability to moderate in the first place. By the end of the first month, inflammatory markers, specifically high-sensitivity CRP, which is a standard blood test, begin to shift in women who have combined the dietary changes with consistent morning exercise. The Knutsor 2025 Geroscience Review noted coffee's association with reduced inflammatory markers in population studies, with effects becoming measurable at the 4 to 8 week mark in intervention studies. At the 2 to 3 month mark, if the coffee protocol has been paired with consistent resistance training or brisk walking, the research supports measurable changes in body composition, specifically a reduction in the visceral fat compartment. This is not dramatic in absolute terms, but visceral fat loss in postmenopausal women is mechanistically significant because of the aromatase activity and inflammatory cytokine production that visceral fat drives. The epidemiological protective associations, the hazard ratios in the 0.90 0.94 range for breast cancer risk, are built on years of consistent exposure. The studies that documented these associations tracked women for decades. This isn't a quick fix or a 1 month intervention. It's the mathematics of consistent daily practice across years of postmenopausal life. A cup of coffee optimized the way the evidence supports, taken daily, becomes a meaningful component of a sustained biological environment that is less permissive to cancer cell survival. There's a broader point worth making here that the research supports, but that rarely gets framed this way. Most cancer prevention information that circulates for women over 60 was either designed for the general population, meaning it includes data from men and premenopausal women, sometimes predominantly, or it was designed specifically for women at high genetic risk. The postmenopausal woman of average risk, navigating a fundamentally changed hormonal environment, is systematically underserved by both categories. The research exists to serve her better. It's just rarely assembled in a way that treats her biology as the primary lens. The 5 mechanisms we reviewed today: chlorogenic acids, glucose, insulin modulation, caffeine's AMPK activation and stem cell protection, chlorogenic acids, WNT pathway suppression, coffee's anti-visceral fat effects, and the diterpene NRF2 connection, all share a common thread. They are more relevant to postmenopausal women not despite the loss of estrogen, but specifically because of it. Estrogen was performing all of these regulatory functions. When it left gaps. Coffee's bioactive compounds, in different and partial ways, engage each of those gaps through mechanisms that don't require estrogen receptors. That's not a coincidence. It's why the protective association is stronger after menopause than before. We started with 335,000 women followed for nearly 2 decades and an adjusted hazard ratio that most of those women will never hear about. The research behind that number involves 5 molecular pathways, a set of practical protocol modifications that cost almost nothing, a clear safety framework for the medications most common in this population, and a timeline of effects that rewards consistency over months and years rather than overnight. What makes this different from the general coffee is good for you conversation is exactly what makes it worth having. The mechanisms that produce these protective associations are not the same in a postmenopausal woman as they are in a premenopausal woman or a man. They're more active, more relevant, and more directly engaged by the specific hormonal landscape that menopause creates. Knowing that changes how you think about the cup sitting on your counter every morning. Navigating health information as a postmenopausal woman is genuinely complicated, not because you aren't capable of understanding it, but because most of it wasn't built for your biology in the first place. The fact that you're here seeking out the research that specifically applies to where you are right now is not a small thing. You've just reviewed the women-specific evidence that most health summaries omit entirely. Not theory, not advice designed for general populations and adapted generically. The science built for women whose biology operates through a fundamentally different hormonal environment. If this investigation was useful to you, the video on stem cell function in postmenopausal women goes deeper into the AMPK and autophagy mechanisms we touched on today. It's the piece that connects why cellular maintenance becomes specifically more difficult after estrogen loss, and what the evidence supports for addressing that directly. Comment below with your biggest question or takeaway from this review. I read every comment, and they directly shape which research I prioritize reviewing next. What the women in this community are asking for tells me where the evidence gap is most urgently felt. Keep investigating. I'll see you in the next one. Dr. Jessica Ward.